Hi there, good afternoon. My name is Jill Olson. I'm working currently as a general neurologist with doctors Miravalle and Miller at Advanced Neurology in Fort Collins. Today we're going to have a brief overview of epilepsy in the allotted time that we're given. Here we go. I have nothing to disclose today. Learning objectives. So first we're going to talk about seizure types, including a new classification system that came out in 2017. We're going to talk about focal epilepsies, generalized epilepsies, refractory epilepsy, and even Colorado's hottest topic right now, cannabidiol or CBD. We'll start off with some terminology, and while most of this is familiar with you guys, at least this will set us all on the same foot. A seizure is a transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neural activity in the brain. Epilepsy is defined as a disease, not as a disorder. So we used to sometimes call epilepsy seizure disorder, and we have taken that terminology out. Epilepsy is when the brain demonstrates a pathologic and enduring tendency to have recurrent seizures. Epilepsy is also defined as one or more unprovoked or reflex seizures with at least a 60% probability for another seizure within the next 10 years. People are not considered to have resolved epilepsy until in adults, a person has been seizure-free for 10 years, at least 5 of those off anti-epileptic drugs. Seizure classification systems have evolved over the years. The newest one comes in 2017 when the ILAE, the International League Against Epilepsy, published a new operational classification of seizures and epilepsies. This is trying to make it more user-friendly for us so we can understand what we're naming and classifying. Instead of partial onset seizures that we used to have, now we call them focal seizures and focal epilepsies. The new 2017 classification system also introduced epilepsy syndromes. These are generally clusters of features that incorporate seizure type, EEG findings, imaging, and other features, including genetics. So this is a look at the ILAE classification that came from 2017. You can see on the left there, focal onset seizures. You can have aware focal onset seizures or impaired awareness focal onset seizures. In those categories, you can have motor onset, such as with automatisms, atonic, clonic, hyperkinetic, etc. Or you can have non-motor onset focal seizures that can be autonomic, behavioral arrest, cognitive, emotional, or sensory. Just like in the old classification systems, these focal epilepsies, or focal seizures can progress to bilateral tonic-clonic seizures. Then you have generalized onset seizures. These can be motor, such as your tonic-clonic that you think of. There can be plain tonic, plain clonic, myoclonic, atonic, and on, as well as non-motor or absence seizures. These can be typical, atypical, myoclonic, or eyelid myoclonia. They also leave us a category for unknown onset. If we don't have MRI or EEG findings, and we classify these by how they look, the semiology, such as motor or non-motor with behavioral arrest. You can also have unclassified seizures, which is when you generally have inadequate information or ability to place it in the other categories. Otherwise, we try not to use unclassified. Focal seizures originally within a neuronal network limited to one hemisphere that may be discretely localized or more widely distributed in that hemisphere. These are classified according to the patient's level of awareness and the first most prominent either motor or non-motor features. Previously, we had simple partial seizures. Now we call these focal aware seizures. Similarly, we used to have complex partial seizures. We now call these focal impaired awareness seizures. Generalized seizures originate at some point within the brain and then rapidly engage bilateral distributed networks. Like we already discussed, they can be motor or non-motor. Absence seizures typically have sudden cessation of activity, often with eyelid fluttering or head nodding. Sometimes there can be other automatisms, and then they have immediate recovery. These can be typical or atypical, myoclonic. We already discussed these a little bit. Generalized epilepsies have one or more generalized seizure types. As you are probably well aware, generalized epilepsy EEG findings show generalized spike and wave activity. These are also supported by clinical signs like myoclonic jerks or a family history of epilepsy. For those of you who like to look at EEGs, this will be readily familiar to you, but you can see the high voltage generalized spike and wave discharges, and these occur about 3 per second or 3 hertz. So this is what an absence spell would look like in generalized epilepsy. In focal epilepsies, patients can have one or even more focal seizure types, so they can be unifocal or multifocal. These focal epilepsy is supported, the diagnosis is supported by focal slowing or focal epileptiform discharges on your EEG or focal MRI abnormalities. This is a look at an EEG of a 29-year-old guy who has a temporal lobe epilepsy. You can see up in the top frame A, if you look at, you can see here in the left temporal electrodes, you start having this semi-rhythmic delta discharges. And then these progress into a little bit faster. They turn into sharply contoured theta waves, still primarily in the left temporal electrodes. Once we get down to C, you're seeing the ictal activity has evolved into these spike and slow wave discharges. Epilepsy syndromes are new to the classification system. And these are typically a cluster of features that incorporate seizure types, EEG, imaging features that classically occur together. Contributory factors include the age of onset, whether or not there will be remission, triggers, diurnal variation, intellectual and psychiatric dysfunction, EEG findings like we already talked about, family history, and genetics plays a large part in epilepsy syndromes. Common epilepsy syndromes you have most likely heard about include childhood absence epilepsy, juvenile absence epilepsy, juvenile myoclonic epilepsy, epilepsy with generalized tonic-clonic seizures alone, and so on and so forth. This is a picture of Angkor Wat just to let you know we're switching gears. So now we're going to talk about some different topics. We're going to start with medications or supplements that lower seizure threshold. I know we're all familiar with particular medications like bupropion or tramadol that can lower seizure threshold. I often forget that beta-lactam antibiotics like ampicillin can do so, and we need to be careful of those. Diphenhydramine or Benadryl is something that patients will often take to help them sleep at night, and they won't even mention it to you because it's over the counter, so be sure to ask about Benadryl use. Alcohol, obviously, we know that lowers seizure threshold. Dalfampridine, otherwise known as Ampera, to treat MS patients. The data is still out on whether or not stimulants can actually lower seizure threshold. There are some studies that seem to indicate that it can and others that refute that. So be careful when your epilepsy patients are on stimulants and watch out for that. We do know that antidepressants will mildly lower seizure threshold, but because depression is often a comorbid condition in people with epilepsy, the benefit is usually greater than the risk in using antidepressants for these patients. Supplements that also lower seizure threshold to ask about include ginkgo biloba, ginseng, evening primrose, yohimbine, ergot, and don't forget your migraine therapies that contain such derivatives, and then herbal remedies like kratom. I actually had a patient that came in a few years ago and he was using high amounts of kratom and he was having seizures as a result. Drug-resistant epilepsy is when a patient has a failure of an adequate trial of 2 tolerated medications, so they weren't stopped early due to side effects, 2 appropriately chosen medications, meaning medications that are known to treat generalized epilepsy if you're treating a generalized epilepsy. And these are appropriately chosen and used, whether as monotherapy or in combination, to achieve sustained seizure freedom. Drug-resistant epilepsy affects about 1/3 of people living with epilepsy, so it's quite common, and it impairs quality of life, family function, social support, and more importantly, it increases the risk of sudden unexpected death in epilepsy, which usually occurs in about 1 out of 1,000 adult patients. Drug-resistant epilepsy is generally more likely to be focal rather than generalized. Predictors of drug resistance include a high initial seizure frequency, underlying etiology of those seizures, and a failure to respond to anti-epileptic drugs early on. Thus far, 3 randomized controlled trials have shown the superiority of epilepsy surgery compared to continued medical therapy in patients with drug-resistant epilepsy, both for seizure control and quality of life. Successful epilepsy surgery is more cost-effective than medical therapy, and even more so if surgical treatment happens early on in the disease course. Patients are considered to be surgical candidates if they're having 1 or more seizures per month and have failed 2 or more anti-epileptic drugs. So this is actually more reasonable than a lot of people think, and it's a good reason to refer people to the EMU earlier rather than later to see if they might be surgical candidates. You might consider surgery even earlier than those above numbers if they have a lesional epilepsy. So they have a structural abnormality like a tumor or a vascular malformation seen on an MRI. About 60 to 65% of patients will be seizure-free if they have temporal lobe epilepsy after temporal lobe resection. That's really good. And about 40% can be seizure-free after extratemporal resection. We're not really sure how many patients are going to be able to stop their anti-epileptic drugs after surgery. We always counsel them that likely they will need to remain on medications for life, but likely can lower their doses. However, we do think that some patients can stop their seizure medications. Surgery can be associated with verbal memory and naming decline, but cognition will actually improve in verbal and visual spatial memory and verbal fluency over time. Surgical complications are usually minor or transient, and the most common is a minor visual field deficit. There's about an 11% minor complication rate and a less than 5% major complication rate, and we're talking about brain surgery, so that's pretty good. Prior to epilepsy surgery, there is extensive testing that happens. Obviously, it includes MRI and video EEG monitoring at the EMU, but likely both phases 1 and 2. There's neuropsychological evaluation, MEG, SPECT, functional MRI, WADA testing, and even PET scans. In phase 2 EMU monitoring, they will likely need, or in some cases at least, they'll need intracranial grids and strips to get stereo EEG recordings. And then there can be resection or thermal ablation with either laser or ultrasound. This is a photo of a 64 contact grid placed on this patient's temporal lobe, trying to locate from whence his seizures arise so that that particular location can be tested and removed. It's pretty good, pretty cool. So there are certain patients with drug-resistant epilepsy that are not going to be good candidates for surgery. Either their epileptogenic focus is an eloquent brain or it's somehow hard to treat otherwise. In that case, we look to other devices for neuromodulation. The first and easiest to use is the VNS, or vagus nerve stimulator. This is implanted in the left chest wall, and there's a lead, a flexible lead that runs to the left vagus nerve in the anterior neck, and it fires off and on 24 hours per day, all the time. Batteries last around 5 years or longer. Its efficacy improves over time, with about 60% of patients achieving a greater than 50% seizure reduction, which is good, but only about 8% will have seizure freedom at 2 years. Then you have RNS, which is responsive neurostimulation. This is where there are electrodes actually implanted in the brain that recognize epileptiform discharges ahead of time and then try to send an electrical impulse to stop that from becoming a clinical seizure. It's a closed loop for detection and treatment of drug-resistant epilepsy. Recent data shows about a 72% mean reduction in seizure frequency over 7 years, so it also gets better with time. We've all heard of DBS, or deep brain stimulation, for Parkinson's disease and essential tremor. The Sante trial looked at stimulation of the anterior nuclei of the thalamus in treating seizures, and this showed us that after about 2 years, seizures were reduced by a median of 56%. Seizures were also less severe and patients' quality of life improved. They're looking now at other locations to place stimulation for deep brain stimulation, like in the basal ganglia, and we'll find out how that comes out in the future. We're switching gears again. All right, a favorite topic in Colorado. Let's talk about marijuana. Cannabis sativa is an ancient medicinal plant. Over 100 cannabinoids have been extracted. The most studied is delta-9 tetrahydrocannabidiol, or delta-9 THC, which is what they loved in the 70s, and this is a psychoactive compound. They've also really studied CBD, just cannabidiol, a non-psychotropic phytocannabinoid. CBD shows low affinity for cannabinoid receptors, but affects serotonin receptors, preferentially 5-HT1A and 5-HT2A. It also affects opioid and non-endocannabinoid G protein coupled receptors, as well as ion channels and enzymes. CBD is actually anti-inflammatory. It modulates pro-inflammatory cytokines like IL-1 beta, IL-6, and TNF-alpha. It also modulates cell cycle and immune cell function. It has antioxidant activity, and it modulates expression of nitric oxide synthase and nitrotyrosine, which reduces production of reactive oxygen species. CBD interacts with transient potential vanilloid receptor type 1, TRPV1, which is a non-selective cation channel that allows the influx of calcium when it's activated. The sensitivity and density of TRPV1 is increased in neuroinflammatory conditions, such as epilepsy. When this receptor is active, it promotes the release of glutamate, which is excitatory, and an increase in calcium, so it increases neuronal excitability. Binding of CBD to TRPV1 leads to desensitization of the receptors, so it thereby reduces inflammation and decreases intracellular calcium. CBD also interacts with T-type calcium channels to block them. This decreases neuronal excitability, and we suspect this is the possible mechanism of the anti-epileptic activity we see with CBD. Adverse effects: somnolence, nausea, diarrhea, and poor appetite. There is a risk of hepatotoxicity with CBD, so I suggest routinely checking LFTs every 6 to 12 months in patients that are on this supplement. Ingesting CBD with fatty meals may enhance absorption up to 4 to 5 times, which is something to remember to tell your patients. Generally, we don't suggest more than 5 milligrams per kilogram per day from non-prescription or artisanal sources, like you can get at shops around. Even I've even seen it at grocery stores lately. Keep in mind that for about a 150-pound person, 5 mg per kilo ends up to be about 340 milligrams per day. Most of your over-the-counter CBD preparations run 10 to 25 milligrams at a dose. I have seen them come in 50 to 100 milligrams at a dose, but these get very expensive. So I think it's unlikely that most of your patients are going to be able to afford to even get up to that 5 mg per kilo per day. There is now an oral cannabidiol solution that is on the market that was FDA approved in 2018. And much of what we know about CBD comes from the clinical trials that led to this approval. Unfortunately, this medication is only approved for 2 generalized epilepsy syndromes, Dravet and Lennox-Gastaut, in patients 2 years of age and older. In the clinical trials for this, it was dosed at 10 to 20 milligrams per kilogram, but some trials actually went as high as 50 milligrams per kilogram. In the clinical trials, 5 to 14% of patients stopped CBD due to adverse effects, but these seemed likely dose dependent. CBD has some drug interactions. It inhibits cytochrome P450, 3A4, and 2C19, so drug interactions happen with multiple medications. Please be aware that certain seizure medications, serum levels will rise when they are taken with CBD, either with a prescription formulation or over the counter. And those include clobazam, topiramate, zonisamide, rufinamide, and eslicarbazepine. Please be aware that when CBD is taken with valproate, there is an increased risk of elevated LFTs. There are other medication interactions, such as with warfarin, which result in increased bleeding risk when these are taken with CBD. And those are my resources. And that's the end. Thank you very much.